Probably don't need to remind people, since you're already on board here, that today is our double day and that we're together again at 1 o'clock. Kind of tough to get together on that second go around on such a beautiful day as this. We'll give it a try though. Okay, let me do a little bit more with this story we were looking at yesterday from Smithsonian. It's a really long article, and so we could take the whole hour doing it, which would be kind of interesting because there's so much fascinating discussion in this particular article, but we of course don't really have time to do that. So let me do another installment here, and then we'll do some more this afternoon also. If you recall, the situation that we're looking at here was in World War II in Italy. And there's a coastal town in Italy known as Bari, Italy, came under air attack from the German Luftwaffe. And the extent of the damage was such that many people have made the analogy that this was a similar sort of thing to what happened in the much better known Pearl Harbor attack. Our particular interest in it has to do with some, as we'll ultimately see, some developments in the realm of biomedicine. And the situation that we're going to be looking at today, this morning, has to do with some of the specifics with respect to the damage that individuals were suffering as a result of being involved in this attack. And there was a physician named Alexander, his last name was Alexander, who had been called into the scene because of expertise that he had with respect to chemical warfare. And so as I go through this, you'll hear reference to this Alexander. So let me just start into this and see what we can make out of this before we knock it off again and launch into our regular lecture. So it goes on to say the first unusual indication the doctors informed Alexander was that casualties did not present typical symptoms or respond to treatment in the typical manner. Many patients, despite a thready pulse and low blood pressure, did not appear to be in clinical shock. Instead of being restless or anxious, they were apathetic. Some even said they felt rather well, and their extremities were warm rather than cold. After dawn, nurses observed that a few of the men complained of being thirsty, even though orderlies had just gone around with the drink carts. Suddenly, there were so many men clamoring for water that the whole ward was in an uproar. Patients were yelling about the intense heat, tearing off their clothing, and in their frenzy, trying to rip off their bandages. Overnight, the majority of immersion cases had developed red and inflamed skin with blisters as big as balloons and heavy with fluid. This, together with widespread nausea and vomiting, led doctors to think the cause might be poisonous fumes, possibly from the fuel oil and or explosives involved in the attack. We began to realize that most of our patients had been contaminated by something beyond all imagination. 6 hours after the attack, patients who had managed to fall asleep awoke complaining of eye pain. They said their eyes felt gritty as though sand particles had gotten in. Within 24 hours, the wards were full of men with eyes swollen shut. As the staff's unease deepened, British Naval Headquarters sent a notification that there was a possibility of blister gas exposure among the casualties. The hundreds of burn patients with unusual symptoms were to be classified dermatitis not yet diagnosed, pending further instructions. Given the crush of casualties that first night, non-urgent cases who had appeared in quote unquote good condition were sent away, sometimes in their wet uniforms. The next morning, many returned, clearly needing treatment. Nurses tried to clean them up, scrubbing the black scum from patients' skin with kerosene, but many took a turn for the worse. We did everything humanly possible, but it was no good. It was horrible to see young these boys so young and in so much obvious pain. We couldn't even give them strong sedatives since we weren't quite sure how they would react with whatever had poisoned them. The first unexplained death occurred 18 hours after the attack. Within 2 days, there were 14 fatalities. Alexander noted the startling downward spiral. Individuals that appeared in rather good condition in a matter of minutes would become moribund and die. The British doctors were mystified. The symptoms did not correspond to case histories of mustard gas poisoning from World War I or to manuals issued by the Chemical Warfare Service. If the toxic agent was mustard, named for its unpleasant garlicky odor, respiratory complications should have been more prominent. Several days later, patients with no previous respiratory problems became congested and developed severe sore throats, making it hard to swallow. These patients died not as a result of bronchopneumonia, as might have been expected, but from cardiocirculatory failure. Physician Alexander walked the crowded wards. He examined patients, gently lifting blankets to study their wounds. With extraordinary delicacy, he probed the dark patches of thick red skin. He spoke with each patient in turn, asking how he had come by his injuries. Which ship was he on? How did they become rescued? Did they receive first aid at the docks? What about the hospital? One sailor after another told him of being caught in the firestorm, of the pandemonium of somehow making it to the hospital. There they had to wait for as long as 12 and even 24 hours before receiving treatment. So we'll go on with that later this afternoon, but we'll call it good on that story for right now. See if anybody has any questions or thoughts up to this point. Okay, if you recall, yesterday we were looking at some further aspects of pharmacokinetics, and particularly later on in the hour, we switched over to a new PowerPoint with some additional detail about drug metabolism. And so we'll continue with that this morning, and then find our way into the drug transporter PowerPoint, and eventually switch over into pharmacodynamics, which we'll certainly continue with this afternoon. So a little, hopefully people are finding their strategies to cope with the stresses that exist as we move deeper into the semester. Black Cat's with us again today. I don't know if she'll wander behind us in this presentation or not, but if not, we can think of her by looking at Schrodinger's cat in this picture. So we went through some definitional sorts of things. Talked about the idea of so-called phase 1 and phase 2 metabolic reactions, in which the phase 1 reactions are the catabolic or sort of breakdown side of it. The phase 2 are the conjugation or synthetic or anabolic build-up side of it, but all leading to metabolites which are more favorable for elimination because of their increased polarity as a result of the biochemical transformation. And a little structural example of some esters and amides undergoing phase 1 hydrolysis. And then we started talking about the very storied family of metabolic enzymes known as the CYPs, or the cytochrome P450 enzymes. A very now diverse, recognized to be a very diverse number of metabolizing enzymes, which are present at very high amounts in the system, particularly in the liver, and have been undergoing intense research with ultimate practical applications for over the last half century. We talked a little bit on this slide that we're looking at now, phase 1 CYP families, about CYP3A4, which for our purposes is receiving a little bit of emphasis because of its incredible prominence in being able to be involved in the metabolism of so many different substances. And then expanded our vision out a little bit into this too cluttered table of various enzymes and drug substances, and I suggested to folks to kind of take a look at some of these things, but to not worry about all the detail, with the exception of 3A4, because in view of our trying to maintain things without excessive stress and strain, this is one of those tables that causes a lot of stress and strain if you have to do the whole thing. We talked about the setting of drug metabolism and some of the factors that are involved in influencing metabolism up or down, depending upon the particular parameter and the particular drugs involved and so on. But they're listed on the left side of the slide are a number of very important parameters which are involved in altering levels of various metabolic events, including, of course, nutritive factors, the practice of smoking, alcohol ingestion, a variety of other drugs, which over the course of the year, we'll see examples of those as we go along. Various other aspects of the environment, including, for example, environmental smoke, and of course the all important realm of genetics. And that's that area of genetics which has expanded so dramatically in this area over the last half century. And when I first heard about these things so many years ago, 50 years ago or so, there were many hints at the time about genetic involvement in these substances, but not a lot of research had been done on that at that point. But in the decades that have elapsed since then, there's been a very substantial emphasis on the genetics of metabolism. And then I think this is about where we left off, where we were looking at a little cartoon relative to CYP3A, and mentioned that as sort of a model system as far as metabolic enzymes are concerned. So even though the cytochrome P450s, and by the way, the sort of biochemical situation that exists with respect to the CYPs is that they're found in high concentrations in endoplasmic reticulum, and that becomes a theme as we go along with respect to their biochemical setting. But despite the huge importance of the cytochrome P450s, there are many enzymatic systems which are separate from the cytochromes. And this slide that we're looking at right now, phase 1 non-CYP drug metabolizing enzymes, gives some examples of that. And I think some of the substances listed in this slide are already familiar to you, and some of them may not be. But let's just emphasize a little bit with respect to the sort of the upper aspects of this slide. Monoamine oxidase is probably one of those metabolic enzymes that you have heard from the biochemical location for the monoamine oxidases, and I should put that in plural because there is more than one, and the differentiation between those types of MAO is a pretty significant one in terms of the outcome for certain drug substances. So notice the moniker MAO, which is probably the way we usually hear this referred to, and the mitochondrial location as far as the subcellular environment is concerned. So the statement there is an important one. MAO oxidatively deaminates endogenous substrates, including neurotransmitters such as the biogenic amines, a number of examples which are listed there, and drugs including the triptans. And the triptans are, I think many of you are familiar with migraine headache. They're an important group of drugs that were introduced about 2 decades ago for the treatment of acute migraine. So anytime various amine substances are influenced by monoamine oxidase in the metabolic realm, that's a significant factor as far as those drugs or endogenous substances like the biogenic amines are concerned. Next step, bullet point down, equally important, alcohol and aldehyde dehydrogenases, which are found really in a variety of locations throughout the body, but particularly in the cytosol of liver. Liver is such an important metabolic organ with respect to many things, but especially with respect to alcohol. And in the multi-step reactions that are occurring following alcohol ingestion, the alcohol and aldehyde dehydrogenases are both very important in that particular regard. And here in a few weeks when we when we're looking at sedative hypnotic substances, and especially with respect to alcohol, we'll talk about these specific dehydrogenases and how critical they are in terms of alcohol metabolism, and how limiting they are in the sense of high alcohol concentrations that the system sees even with modest ingestion of alcohol. Saturate out these enzymes, leading to a move from first order to zero order kinetics, and implications that has for the ultimate time frame of the action of alcohol and its metabolites. And so there are a variety of other oxidases listed in this particular slide, but I wanted to especially emphasize the upper aspects of it because of critical importance to a number of the things that we'll be studying as we proceed. So if you recall, the phase 2 biotransformations are example of anabolic metabolism, or in other words, sort of the building up of the substances to a larger size rather than breaking them down to smaller, which occurs in the phase 1. And the phase 1 sorts of things are the types of reactions that I suspect you might readily anticipate heading into a subject like this because of their catabolic nature. But the phase 2 synthetic and anabolic reactions are a bit of a surprise, perhaps, but equally important in terms of preparing substances for ultimate elimination because of their polarity. And so some examples of phase 2 reactions are listed in this slide. And I might particularly note their third bullet point down, glutathione conjugation, because glutathione is such an important biological molecule in the context that we're looking at it here, but also in a variety of other realms. And stay tuned on glutathione because it will definitely provide interest to us as we go along throughout this semester and next. Uh, that said, very common phase two synthetic reactions include acetylations, glucuronidations, which are essentially tagging a sugar molecule onto the target for the biotransformation, and sulfations. And here's just a nice little structural look at glucuronide formation. You can see that kind of sugar-like moiety there in these particular reactions. So uh, in, I'm not sure what Katie will do, but in my views of pharmacology-related things, we refer to structural things quite a bit, but I don't really do a lot of emphasis on structures, rather leaving that to the experts like Katie and others from the realm of medicinal chemistry. So you won't, from me, you won't find structures showing up on exams. You certainly will, I'm sure, in medicinal chemistry. But nevertheless, we like to refer to the structural basis of pharmacology, which is medicinal chemistry, and the incredibly tight relationship that exists between medicinal chemistry and pharmacology, as well as the tight relationship that exists between those two and pharmacokinetics, which we've been emphasizing here in the early going in the course. So phase one and phase two can be viewed as sort of, in a sense, kind of separate entities, but they can also be viewed as related sorts of progress throughout a metabolic scheme. And indeed, many times phase one and phase two reactions are coupled with each other, leading to a little bit more complex metabolic schema. And here we're looking at an important anticonvulsant drug known as phenytoin or diphenylhydantoin. You see it names used in both those regards. I think phenytoin is now kind of the more accepted version of the name relative to a few decades back when it was referred to as diphenylhydantoin. So phenytoin has been around for a while. It's a very broadly based anticonvulsant from the standpoint of being useful in many different subtypes of convulsion or epilepsy. And we will talk about the anticonvulsants a little bit along the way this semester. Some of them specifically in the realm of the sedative hypnotic drugs. And so, for example, Valium itself is an important anticonvulsant as well as sedative hypnotic, and then phenytoin. So stay tuned for a while on that one. It'll be a while before we get to that specific realm of anticonvulsant action. But here it's a good example to follow in sort of the dualistic metabolism that is occurring first in the realm of the CYPs and in a phase one transformation, and then a phase two conjugation to sort of lead to a much more polar hydrophilic sort of substance, allowing for elimination, in this case particularly via the bile and the gastrointestinal tract. So here's where we get a little bit more detail from a cell biology standpoint. And notice the emphasis in this slide, biotransformation continued on the endoplasmic reticulum. So that, from a research standpoint, when you isolate an endoplasmic reticulum, that fraction in the differential centrifugation is often referred to as the microsomes. So don't be surprised, particularly with respect to the SIPs, if you see this designation uh, microsomal rather than endoplasmic reticulum, but it's referring to the same thing, just an alternate form of description. So here's a nice, hopefully nice little cartoon for you, emphasizing the endoplasmic reticulum as being source of enzymes for metabolic reactions. And then with respect to the SIPs themselves, the cytochrome designation there, you can see with the iron playing such a key role in the biochemistry of these enzymes, and of course the theme we have there is of heme, and you are already well familiar with the heme structure relative to your biochemical studies in the past with respect to hemoglobin, myoglobin, and so on. So there's a very definite structural relationship via heme with respect to the SIPs and previously studied biochemicals. Gives you additional rationale for, it's pretty obvious why heme is so important with respect to oxygen transport in the blood, but here's even greater rationale for studying heme as it shows up again here in these metabolic realms. So we talked a little bit yesterday about the idea that biotransformation can lead to deactivation or lowering activity in some cases. In other cases, it might not result in much of a change at all in that regard. But of course, the importance, even when there's not any bioactivation, is that the substance is more polar. But we can also extend this further. Not only can certain biotransformations result in decreased activity or very little change in activity, but can lead to increased or bioactivating phenomena. And so that leads to the whole realm of pro-drugs, which is such an important thing dispositionally. And as we talked about yesterday, harkens back to the physiological realm when we talk about pro-hormones. And in that regard, you might specifically think of insulin and glucagon, in which there are prominent pro-hormones leading ultimately to the transformation to the active physiological substances themselves in terms of insulin alone and glucagon alone. That transfers over into the whole realm of drugs, and the idea of pro-drugs is eminently important in a number of different examples along the way. So here's a interesting example of conversion of a prodrug in the realm really of the genome, and topoisomerase is involved there, and keep that in your back pocket a little bit in terms of importance later on. Not so much this semester as next semester when you're talking about the realm of cancer, chemotherapy. More details here, and with relevance to an important substance like carbamazepine, which we'll encounter this semester in a couple of different realms. The most widely based realm, of course, I suppose, is in the anticonvulsant realm, but there's also a lead into the pharmacology of migraine headache, because certain types of migraine are very much aligned with anticonvulsant activity. And so perhaps it's not surprising that some anticonvulsants, such as carbamazepine, are not only found in the anti-epileptic area, but also in the anti-migraine area. And for a long period of time, which is starting to end now, but for many decades, the need for chronically useful prophylactic types of drugs in migraine was very severe. And so a lot of examples of prophylactic anti-migraine drugs crop up with respect to other more familiar drug categories. Now, just within the last year or two, some very important additions have been made to the anti-migraine chronic realm, and we'll talk about those later this semester when we deal with the acute and chronic migraine drugs. So, the catch with respect to many of the substances that have been used in prophylactic treatment of migraine is that none of the drugs were as uniformly as effective as we would like. And of course, they all bring along with them certain aspects of adversity, which are unwelcome. So the anti-migraine area has been a one of incredible interest over the last couple of decades in terms of research. And finally, that's coming to fruition with some of these newer substances just out again in the last few years that we'll talk about later on. But nevertheless, over the last many decades, other drug substances such as the anticonvulsants, such as carbamazepine, have been important in the anti-migraine realm, as well as the broader anticonvulsant realm. So xenobiotics are the terminology referring to foreignly introduced substances in the system. Is the reason for this particular designation in this slide. And this is just one of those, pretty cluttered types of slides, but trying to bring together a number of different phenomena that we've been talking about in the last few minutes and hearkening back to yesterday also in terms of hydrophobicity, hydrophilicity, phase 1, phase 2, and ultimate elimination of the very polarized substances because of the transformations that have been occurring. So we often try to do summarizing types of slides, which this one does that in a sense, but it also can potentially lead to some confusion as we try to piece all those variables together. So that is a little bit greater look at metabolism in terms of some of the specifics of phase 1 and phase 2 reactions, especially. But now let's take another step here, if I can. So see if I can get our next set of slides up without too much turmoil. So I'll move through this fairly readily, rapidly. I'm sure we won't get done with it this morning. We'll do a little bit more this afternoon and then use that as a bridge into the realm of pharmacodynamics, because membrane transporters are specialized biomolecules that are not only important in terms of the transport of physiological substances and drugs, but are also, in a sense, receptors in their own regard. And therefore lies the nice little transition that hopefully we can make between the realm of transport and the realm of pharmacodynamics. And once again, remind everybody that fortunately for our purposes, we have an expert in Katie on board in terms of the transporters. And I'm sure you'll be hearing a lot about transporters from her as we proceed this semester. And Katie, feel free to chip in today too, if I'm leading the discussion in the wrong direction as far as transporters are concerned. But this is another amazing area of development in terms of biochemistry and pharmacology over the last few decades. Uh, to a limited degree, when I was first involved with pharmacology, there was recognition of the placement and value of transporters. But it was a much more sort of isolated view of transport that we had at that time, compared to what we see now with the huge developments that have occurred in this area and which are continuing to occur. It's a lively area of research, and many individuals in our uh, department and school are at the cutting edge of learning more about transporters, and Katie is certainly an example of that. So right now we're just sort of brushing through this fairly quickly to increase our awareness of the import and presence of transporters, but it'll be a thematic sort of matter for us throughout the year. And so this overview slide here is just trying to uh, make us aware of a number of different various sorts of transport phenomena that occur biologically, um, all of which are important in one way or another, ultimately to pharmacology. And so we have membranous channels, which you're probably already fairly familiar with, because the study of ion channel behavior is a long-standing one. We can even go back into the just post World War II era in the late 1940s to see developments that occurred in the study of ion channels, such as sodium and potassium channels, and ultimately resulting in the Nobel Prizes to Hodgkin and Huxley and Katz for their work, particularly with action potential phenomena associated with the nervous system. So the study of channels, both in a research sense and in an academic sense, is a well entrenched sort of area. And so very, very likely you're quite familiar with that realm already. And again, there'll be more emphasis on that as we go along throughout the semester, because of the tremendous involvement of ion channels in the realm of central nervous system pharmacology, which you'll be hearing from both myself and Katie, but especially Katie in that particular regard. But there are other realms of transport, such as carriers and pumps, that are of great importance to us beyond the realm of channels themselves. So this next slide just details some important aspects of transporters as being membrane-bound proteins with a fairly large number of genetic elements devoted to these particular large membrane proteins. And you can see both influx and efflux, in and out sorts of matters associated with these substances, and some important areas of application, such as nutrition, ion-based physiology and pharmacology, the environment, drugs, of course, are our particular interests, and other xenobiotics, including toxicants, which might not normally be listed in the realm of drug substances or pharmacology. And just a catch-all sort of cartoon slide suggesting the roles of transporters in a wide variety of tissues, perhaps all tissues. I don't know if I don't think I could come up with an example of a tissue in which transport phenomena is not important. So with such broadly based importance as that, no wonder that the study of transporters is important to us, not only in terms of rate-related phenomena and pharmacokinetics, but in terms of actual drug action in pharmacodynamics. And so once again, we're sort of slowly edging our way towards that tie-in with pharmacodynamics. And although this first semester of pharmacology might emphasize nervous system phenomena, throughout the year, all of these tissue and organ-based settings are important for our study of pharmacology. And of course, since the nervous system is involved in regulating and controlling matters in all these other tissues, the emphasis on other tissues arises fairly rapidly as we're studying the nervous system because of the connection to the other organs and tissues. And again, next week when we launch into autonomic pharmacology, we'll see that right away as the autonomic nervous system is incredibly involved in regulation of all the tissues that you see in this particular slide here. And we've just gone through talking about a variety of other pharmacokinetic phenomena, so I'm not going to belabor that point anymore. And just to point out that, you know, in pharmacokinetics, as we've talked about, we're talking about drug disposition, or basically how the system impacts the drug. In pharmacodynamics, how the drug affects the system, and the tie-in between those two. And it's that tie-in that's so critical to us in terms of our early going here in the first few days of pharmacology. By the end of the hour this afternoon, we should be firmly into the realm of pharmacodynamics. And we see some examples of that right here. So this is probably a good place for us to make a stoppage for right now. Have a good lunch hour, everyone. We'll see you again this afternoon at 1 o'clock, and we'll start with this slide at that point, as well as doing some more with the amazing circumstances of the tragedy that occurred at Bari, Italy in World War II. So enjoy your nutrition, everybody, and see you again in an hour.